Maybe in our last minute here, I'll say, what have we learned over 10 years in these and what's coming forward? Maybe I'll start with you, Chris, and then I'll come to you, Rob. What are your messages for patients around NOAC use and for doctors who are taking care of these patients?
Well, I think the place we should start is where do we have absolute confidence with high quality data that one will get much greater benefit than risk. And that's the patient who has atrial fibrillation, CHADS VASCOV2, has a 12-lead EKG that has that atrial fibrillation on it, which is a simple way to say that's someone who had enough burden that they would have gotten into the trials.
Yeah.
And for that population, again, we still know, I think the biggest single, the biggest single advance we've made is we've got a lot of patients now who are, at least half who are on a NOAC and therefore are on better therapy than warfarin. And still the next most important thing is get another, I think about half of the gap of this 40%, let's say, who are not on an anticoagulant. I think 20% of them should be. And if they were working in a coordinated way with good clinicians, good information from Google, I think we would save a huge number of disabling strokes if we get a larger proportion on NOACs.
I think that's a big message. Rob, what are your take-homes over our...
Well, first of all, I just want to reemphasize the most important thing, I think, is what Chris said. Where we have definitive, proven benefit that exceeds risk, we need to get as close to 100% as we can in appropriate use of that treatment. And I think that needs to be a huge focus. And then there are three things that I would point to that we've discussed where I think we really need to work. The first is hidden in this decision support discussion with the patient. I think one of the key things is an intracranial bleed or a bleed is something that's concrete. People understand it. It happens. It's scary. Preventing a stroke, no one knows in whom the stroke was prevented. It's a probabilistic, future-looking executive function that has to be exerted. And that is extremely difficult as a concept for most people to deal with. And so point two, this discussion more than anything has got me fired up. We got to move to home. I mean, if all you get is a once every 6-month visit with your primary care doctor, and if you're lucky enough to get referred to Dr. Patel's cardiology clinic and he's not too busy to have a discussion, you do okay. That is just not a good approach to the public health and the way that people should be treated in this day and time. And the third thing I point to that you've all brought up in one way or another, we're still stuck in a relatively arcane evidence generation system. Everybody has an electronic health record now. Data is abundant. Sensible data that's curated and well organized is not there. So if you just take the medically ill, I'm as convinced as you are that a lot of people with chronic medical illness and certain types of cancer, have very high event rates. I'm 100% sure the treatment would work in them, but for whatever reason, our gears are not enmeshed to generate the risk characteristics that would identify the people who benefit. Then, of course, in people who are critically ill, the last thing you want to do is to give them an anticoagulant, given all of their other problems, if there's not a benefit. So it's really important to get it right. So I think we got to move to a whole different evidence generation system that's where the data are not blocked by the academic health systems, for example. But it's also got to have elements of trust, which, I think you made the point very well. People do trust their clinicians now, especially nurses, I might add, much more than doctors. That's where the trust lies. So we have to bring these elements together.
Sean, maybe I'll come to you. Any take-home points beyond what Rob just gave us?
Yeah, I mean, I think that the biggest issue is that we've worked so hard to generate all this evidence, and I think the implementation piece is where we still need to focus. And NHLBI, AHA, a lot of organizations, PCORI, are all trying to help focus us on proper implementation and use of these medications. The FDA is interested in this issue as well. And so I think that we need to be better at working together as a clinical community to really implement the strong evidence generation that we have.
Nothing really to add. We've got tremendous data, very solid data, and we're not implementing it.
Yeah.
So my final word is bye-bye aspirin.
Yeah, I was gonna take it a little farther. I mean, I think we've seen something interesting, and I'll echo what you said, Rob. I mean, let me be clear. I think in the next 5 years, more than 50% of our practice is going to have to be not directly face-to-face sometimes with the patient, but touching them in different ways if we want to stay where we can get to them and they can get to us. And so we really are going to need help with a lot of people. But in this day and age, with the high-quality evidence we have for NOACs and AFib, I would say the first message is use. We still have not enough use in those patients that can benefit. The second message for me would be dose. Get the dose right. And we talked a lot about how we should be working to do that, but that's number two. Number three is aspirin. As Bernard has told us, bye-bye aspirin. I might even make it a little bit even more powerful in that we've lived so long with more we've been sort of platelet-centric, I'll say, with more antiplatelet, whether it was different strong antiplatelets, agents that helped with it, 2, 3 different things. And I think the evidence over the next few years is going to start showing us that different doses of these other pathways and other compounds, certainly with NOACs, is going to be valuable. And then I think the last thing for our clinicians out there is the hierarchy of what you're treating. Know what you're treating. So I would say in the NOAC world, if you have VTE, treat that VTE as a treatment algorithm, and then AFib if you're preventing stroke, and then VTE or thromboprophylaxis, and then CAD, PAD chronically. Because I think what people get confused is when the overlap happens, that's happening. And use proven drugs at proven doses, things that have been studied. Don't sort of generalize. I think that's the other issue. I want to thank you all for joining us today. And thank you on behalf of our panel. We hope you found this peer exchange discussion to be useful and informative.